All right, future clinicians, let's dive into the pharmacology of peptic ulcer disease. Now, this isn't about just memorizing a list of drugs. Nope. This is about building a strategic toolkit, knowing exactly how to fight back against PUD. We're going to go drug by drug, mechanism by mechanism, so you know precisely which tool to grab and when. Let's get right to it.
At its core, a peptic ulcer isn't just a sore. It's a breach in the stomach's defenses. It's really a battle lost against aggressive factors like acid and pepsin. And our job, using pharmacology, is to step into that fight and restore the balance, either by weakening the attack or by seriously strengthening the defense.
So, to figure out how our drugs actually work, we first need to understand the factory they're targeting. Let's do a super quick recap of how the stomach produces acid in the first place.
As you'll definitely remember from physiology, the parietal cell is basically an on-demand acid factory. It gets its production orders from three key signaling molecules. You've got acetylcholine from the vagus nerve, gastrin from G cells, and histamine from those nearby ECL cells. These three signals are the main on switches we're going to target with our drugs.
Okay, so our first major strategy is to get control of that acid production. We're going to look at three different ways we can tame the factory, moving from the most direct approach all the way to the most powerful. The simplest, most straightforward way to deal with excess acid, you just neutralize it right after it's been made. You can think of this like cleaning up a spill directly on the factory floor. And this, of course, is where antacids come in.
The mechanism here is honestly just straightforward chemistry. Antacids are weak bases, they react with hydrochloric acid, and that reaction forms salt and water, which raises the stomach's pH. Simple. Now, there are two main types you should know. Absorbable ones like sodium bicarbonate, which can have systemic effects, and the non-absorbable ones like calcium carbonate.
All right, let's talk high-yield clinical pearls for antacids. They work fast, but that relief doesn't last very long. A key side effect you absolutely have to know for your exams is constipation from calcium carbonate. They can also chelate or bind to other drugs like tetracyclines, which stops them from being absorbed. And a classic board question involves milk alkali syndrome, which is a risk with chronic high-dose use.
So neutralizing acid is great for quick relief. But what if we could stop it from being overproduced in the first place? Our next strategy is much more targeted. We're going to block one of those key on switches that we saw earlier.
H2 receptor antagonists, like famotidine, do exactly what their name says. They go after the histamine H2 receptor on the parietal cell. By competitively blocking histamine from binding there, they effectively turn down the signal for acid production. This is especially good against nocturnal acid secretion, which, as you know, is largely driven by histamine.
Now, a quick but really important aside. You might be wondering, hey, why don't we see ranitidine used much anymore? Well, this timeline tells the whole story of its fall from grace. Concerns that actually started decades ago all came to a head in 2019, when research confirmed that the ranitidine molecule itself could degrade into something called N-nitrosodimethylamine, or NDMA, which is a probable human carcinogen. This, of course, led to its withdrawal from the market and serves as a powerful lesson in pharmacovigilance. Okay, so blocking one signal is good, but the most effective way to stop acid production is to shut down the final step, the main production line itself. And this is the job of our most potent class of drugs, the proton pump inhibitors, or PPIs. But before we get into how they work, we need to understand a key concept, the prodrug. A prodrug is basically a medication in disguise. It's inactive when you take it. It only becomes active after your body metabolizes it. And this is absolutely crucial for understanding how PPIs work so incredibly well. So let's trace the journey of a PPI like omeprazole. It's taken in an acid-resistant coating so it can survive the stomach's harsh environment. From there, it gets absorbed into the blood and travels to the parietal cell. But the real action, that happens when it's secreted into this tiny, highly acidic channel called the secretory canaculus.
And this is where the magic happens. In the extreme acidity of that canalulalis, we're talking a pH below 2, the inactive prodrug is instantly converted into its active form. It then physically binds to the proton pump, the H plus K plus ATPase, and forms an irreversible covalent bond. It doesn't just block the pump, it permanently disables it. The body literally has to make brand new pumps, which is exactly why PPIs have such a long duration of action.
So what are the crucial clinical pearls for PPIs? Well, because they target active pumps, patients have to take them on an empty stomach before a meal. That's a huge counseling point. And while they last a long time, long-term use has risks, like an increased chance of a Clostridium difficile infection. They can also inhibit the activation of the antiplatelet drug clopidogrel. And finally, always be aware of potential rebound acid hypersecretion when a patient stops taking them.
Okay, let's put it all together. This table gives us a fantastic comparison. You can think of antacids as the sprinters, fastest onset, but they have the shortest duration and are the least potent. H2 antagonists are your middle distance runners, and the PPIs, they're the marathoners, slowest to get started but by far the longest lasting and the most potent of the bunch.
Okay, we focused heavily on offense, suppressing acid. Now let's switch gears and talk about defense. How can we reinforce the stomach's own protective mucosal shield?
A really cool example of a defensive agent is sucralfate. I like to call it the biobandage. In the stomach's acidic environment, it undergoes this incredible transformation, cross-linking to form a thick, sticky paste. This negatively charged paste then binds selectively to the positively charged proteins that are exposed in the raw ulcer crater, forming a physical barrier that protects it from acid and lets it heal.
Another key defensive player is misoprostol, and its utility is very specific. Remember how NSAIDs can cause ulcers? They do it by inhibiting prostaglandins, which are crucial for producing protective mucus. Well, misoprostol is a synthetic prostaglandin E analog. It literally replaces what the NSAIDs have taken away, which makes it the perfect choice for preventing or treating NSAID-induced ulcers.
Okay, so we've reduced acid and we've bolstered defenses. But for a ton of patients, the root cause is a bacterial invader. So our final strategy is to go after the primary culprit behind most peptic ulcers, Helicobacter pylori.
Now, eradicating H. pylori is not a job for a single drug. Because of widespread resistance, the standard of care is always multi-drug therapy. A typical regimen combines a PPI, which helps the antibiotics work better in a less acidic environment, along with 2 or 3 antibiotics. Some common combinations you'll see are quadruple therapy with bismuth, or a regimen known as concomitant therapy.
Let's take a quick look at a couple of these antibiotics. Tetracycline, for example, works by binding to the 30S ribosomal subunit, which basically just shuts down bacterial protein synthesis. But beyond the mechanism, the most important clinical pearl, the one you'll never forget, is one of its most famous side effects: permanent discoloration of teeth, especially in kids. This is a huge counseling point.
And to round out our regimen, we have other workhorses like amoxicillin, which targets the bacterial cell wall, preventing it from being built properly. And then you have metronidazole. It's actually a prodrug that gets activated inside the bacteria into a toxic metabolite that literally fragments the bacterial DNA. All these different targets working together to ensure we get rid of that bug.
So there you have it. We've assembled our toolkit. We've got drugs that neutralize acid, drugs that block its production, drugs that build up defenses, and drugs that eradicate infection. With this pharmacological arsenal at your disposal, the question for you as a clinician isn't really, can we treat an ulcer? The real question is, given the specific patient in front of me, what is the most precise weapon for the job? And that, my friends, is the art and science of pharmacology. Thanks for watching.